Good afternoon to you. Good afternoon, everybody. We are talking about the vertigo, general things about vertigo today, and the, Dr. Shi, you will put the slides.
Yes, sir. Please allow me few
Yeah,
seconds.
yeah, you are allowed. You are allowed. I'm waiting for you, ma'am. Vertigo is a very common symptom. In fact, the term vertigo means medically a sippening sensation. But many patients can misinterpret vertigo, and they can think their heavy head is also vertigo, their postural hypotension, blackout, dizziness is also vertigo. They can say that if they don't walk well, sway, they can call it vertigo. Heavy head, low mood with heavy head can also be termed as vertigo by patient. So it's very important to understand the real meaning of vertigo as a patient states. Our presently we mean by vertigo sippening. The true, this is true vertigo, and it's very important for diagnosticians to be very sure about what the patient is telling. Can I have the second slide, ma'am? Yes, this is very important. That's what I was talking about. Many patients say, I have imbalance, I have lightheadedness, I have pricking in the head, neck discomfort, fainting feeling, visual blackout. That is not vertigo. Vertigo is sensation of movement around by the surroundings should be moving, either rotatory or they can be even shaking sometimes. That also would be a type of vertigo. The environment is not in static position. Can I have the next slide, ma'am? Okay, as I told you previously, it's very common symptom of presentation to various specialties, to physicians, to neurologists, to neurosurgeons, to orthopedicians, to ENT surgeons, even to cardiologists. I have seen many patients of vertigo landing up in cardiology ICU units. They even get a coronary angio done there. They even get a stenting done there when the vertigo is due to some vestibular or a central nervous system reason. But it's very important to have an exact diagnosis of vertigo. It's very important not only to make a diagnosis of vertigo per se, but to know the cause of vertigo. And very important emphasis is the cause, because it can matter a lot to patients' welfare and future. Can I have the next slide, Dr. Jayashri? Okay, vertigo, the system of see the our whole environment is stable. I won't go into the reason that it is due to eyes, due to postural, but more important is the vestibular system and its connections to the brainstem and cortex. Therefore, we have two major divisions of vertigo. One could be a vestibular disorder, other could be a central disorder. Vestibular, we call it peripheral vertigo. Central, we call it the brainstem and its connections. And as the slide shows, peripheral vertigo is usually due to disorders of ear, vestibular nerves, or CP angle, while central are due to lesions of the brainstem or its connections. Can I have the next slide, ma'am? As I told you, vertigo can be sometimes, patients can be admitted with coronary artery disease, with arrhythmias, with syncope, or if you have a hypotension due to hemorrhage anywhere. I've seen many patients of GI bleed being admitted in neurology wards with vertigo when they have a postural hypotension. But it's very important as you to be precise and have a systemic examination to be done in a patient who presents with vertigo. Can I have the next slide now? Yes. Okay. Now, this would be how we diagnose vertigo, and these all this slide tells us that to diagnose vertigo, it is very important to know how the patient presents, how it happened, and how is it coming repeatedly, is it coming in a monophasic illness, or is it coming over months and years, or is it happening over seconds to minutes. We'll expand it in the next slides as we go on. The most important thing when a person presents with vertigo, suppose he comes with vertigo to our clinic, the most important is it peripheral vertigo or central? Because peripheral vertigos are usually benign. Central is very important to diagnose because it could be a stroke where immediate treatment is very important. And if you go through this slide, the major differences are when you have a peripheral vertigo, patient is severely vertiginous, he has severe vertigo, but if you examine, there may not be many signs in him. While in a central vertigo may not be that severe, it could be even severe, but he has other neighborhood symptoms and signs. He may not be able to walk, he may have diplopia, he may have speech, so many things. And vomiting is always present if you have severe vertigo. I think peripheral vertigo being more severe, you find more vomiting, but it could be in the central also. And postural instability is mostly in central vertigos, and hearing disorders are more common with peripheral vertigos, and type of nystagmus is a little different in central and peripheral peripheral type of vertigo. And usually, again, this is not absolute duration. Usually peripheral vertigos are transitory. Central vertigo can go for a longer time, but they can also be recurrent and transitory. We'll come to that later. Can I have the next slide, ma'am? When a patient's present with vertigo, it's very important to tell them, to describe the vertigo. Is it rotational? Is it positional? It is constant in every direction? Or it is, as I told you, is it only dizziness and visual blackout? Rotational and positional you have to elicit, because that can give you a clue about the site, is it peripheral, central, and even about the etiology of the vertigo. Can we have the next slide, ma'am? Okay, these are the very important provoking factors. Change of head position means change of position of head. In previous times, when we would, patients sometimes would say change of position of head would lead to vertigo, we made another diagnosis of cervical vertigo. I don't think this exists as such. The change of position is because of the vestibular disturbances. And this is mostly found in all types of vertigos, but more common is it with peripheral vertigos. Even central vertigo sometimes can change with head position. And if you are having recurrent vertigos and headaches in during periods and during sleep deprivation or otherwise, this may be a comorbid condition with migraine, which we will call vestibular migraines. And the lower two are not actually the vertigos, they are anxiety spells, you get it. And loud voice or noise precipitated vertigo can be due to sometimes labyrinthine fistulas can be there. Can I have the next slide, ma'am? Duration of vertigo is important. That can give us you clue about the site of lesion and the cause of lesion. If it happens few seconds, usually it is a peripheral reason, and usually due to, say, seconds due to benign positioning vertigo or perilymphatic fistulas, or in sometimes Meniere's disease. And once a patient is recovering from a vestibular neuronitis, you can get whatever, which can be for seconds to minutes. If it remains more than minutes to hours or day, you should think of a TIA or a stroke. Again, hours recurrent, you can have menias and univestibular disorder. And if it remains for weeks and days, you could have vestibular neuronitis, stroke, or recurrent lesions of brainstem, kind of like an MS or some other compressive symptoms in posterior fossa. And psychogenic vertigo usually stays for longer time. Is it intermittent? It is constant. It has no definite features, and there is no true rotatory sensation in there. Can I have the next slide, Dr. Jayashri? Okay, I emphasize it's very important to diagnose vertigo, because then only you can take care of it, and it has to have an integral and multinodal approach. Means you have to take care of so many things, what drugs to use, what are the physical measures to do that, and does he need urgent intervention if he is presenting first time to you. Can I have the next slide now? I will go to the drugs which we use in vertigos in general and peripheral vertigos in particular. The usual drugs are the vestibular suppressants like antimuscarinics, hyoscine, antiemetics, cyclizine, metclopramide, prochlorperazine, and promethazine, and some calcium channel blockers like synarzine, and even diazepam can work for vestibular as a vestibular being a GABA agonist. Then we have vestibular stimulants like histamine derivative betahistine, very popular and widely used, and some nootropic drugs can be used. We don't have total evidence, but we do use ginkgo, lextrag, igargoline, pentoxifylline was used previously also. Can we have the next slide now? The vestibular suppressants are histamine antagonists, and they decrease the level of histamine in brainstem, inner ear and brain, and they suppress these activities, and they do provide temporary symptomatic relief from nausea, vomiting, and vertigo. But long-term use should usually avoid it because they hamper vestibular compensation. Vestibular stimulants are histamine analog, HI agonists, H3 antagonists. They increase the level of histamine in vestibular nuclei and help in achieving accelerated vestibular compensation. And hence it is a stimulant. Increased histamine causes vasodilatation of vessels on inner ear, brainstem through its activity on H3 receptors, and provides a better vestibular health. And we can give these vessels for longer time, months or even longer than that. Can I have the next slide, Dr. Saab? This is a list of drugs which is available in market. The anticholinergics are scopolamine, antihistamines, diphenhydramine, cyclizine, dimenhydrinate, meclizine, hydroxyzine, synarzine, flunarizine, and the lower list is various diazepam, lorazepam, and clonazepams. Can I have another slide now? Okay. You have a lot of side effects with these drugs, and they should be taken care of, especially in elderly people. Very important. They can have dry mouth, constipation, tachycardia, glaucoma, urinary dysfunction is very important in elderly people or even in younger people. And histamines, they cause a lot of drowsiness, and long-term use can cause weight gains. And sometimes you can get tremor and dysarthria due to dopaminergic drugs. Can I have the next slide? One of the very common drugs which we used in peripheral vertigos is betahistine. It is a non-sedating anti-vertigo drug, and it has a huge window of dose window which I call. It can be used from smaller 1632 milligrams to 72 milligrams a day without much issues with the patients. And for several months, if you use 48 milligrams daily, is very effective treatment for various types of peripheral vertigos. And we have seen that even if we use higher dose, this doesn't cause much side effects to the patient and has to be given in some vertigos, especially Meniere's disease. Otherwise, in Meniere's there is no pharmacological cure, but we have seen betahistine doing wonders where if we use it for a long time. I personally use it for long term in patients, high dose initially and then a maintenance dose of say 32 milligrams or more or 48 milligrams per day for a longer duration. And one can slightly reduce in Meniere's and they can get well with a lower dose then later. Can I have another slide, ma'am? Okay, the next slide. We use betahistine very commonly now, and it is very safe, and the monitoring is not much. It doesn't produce problems with say blood counts, hepatic functions, bladder functions, or the drowsiness is not there, and patient on histamine can work well. In Meniere's disease, a lot of other treatments have been present for times immemorial, like salt reduction, acetazolamide, steroids, labyrinthectomy, vestibular nerves. I think if you use good dose of histamine, you will do well with the patients. The other things don't have much evidence for them. Next slide. It's an open label baseline corrections in an open label multinational study of beta in recurrent peripheral vestibular vertigo. More than 2,000 patients with peripheral vertigo were included in this, and DHI, HADS and SF were used to evaluate the efficacy of treatment. Significant improvement in DHI scale and progressive significant improvement in HADS-A and HADS-D scores, which were statistically significant. And the dose of beta-histamine was 48 milligrams per day for recurrent peripheral vestibular for 3 months, and which was very well tolerated, and it made the patients quite well. Next. And peripheral vertigo and appropriate use of betahistine to improve outcomes. The recurrence involves spinning and sensation. Okay, I'll read the key consensus of this group. Recurrence versus residual dizziness. Recurrence involves spinning sensation and disposition, often occurring in the first year after the incident. Residual dizziness is non-spinning without the spinning persisting after repositioning maneuvers. Role of betahistine is it helps reduce frequency and severity of recurrent vertigo and residual dizziness, and improves vestibular compensation by increasing histamine level, as I said earlier, and increases even blood flow to the inner layer. The dosage is 48 milligrams per day and is very effective for managing vertigo and reducing symptoms and improving quality of life, and which has to be given more than 3 months, and has to be given for months minimum to make it very effective. Next. Okay, this is after BPPV management, exploring pathophysiology and treatment beyond canal 3 positioning. You know the causes of BPV, or it can happen at any age, probably thought to be calcium deposit, whatever it is, and this can be recurrent and very annoying and very inconvenient to the patient. It affects the lifestyle of patients, and one is a physical maneuvers. But we have seen betahistine does help in them by improving microcirculation, regulating intracellular calcium in endolymph, and promoting vestibular nuclei rebalancing, improves brain arousal and vestibular. And even we give calcium and vitamin D, which probably helps the deposition of the removal of calcium autocomplete. Jayashree, please take over now. Okay?
Sure, sir.
Thank you so very much.
Thank you,
I think we made it a little. ये कौन? जबरदस्त में याद है